Hello, everyone. Thanks for joining us to talk about this chronic and intriguing topic. I know it's a problem a lot of parents and families face, so hopefully we can shed some light on things and help out a little bit here. So bear with me as I start my first webinar. So bedwetting and constipation, a super common problem. I'm sure most of you, if you have toddlers, have seen the book Everyone Poops. It's a good book. You should check it out. Helps with some of our kiddos to know that everyone poops. But it is a super common topic. In fact, over 5% of general pediatric office visits year to year are related to constipation and pooping problems. And even up to 25% of pediatric GI specialists have visits related to constipation. So you are not alone in dealing with these questions and concerns. So talking about the nighttime bedwetting, it's called Enuresis, and it's involuntary wetting where the kiddo cannot control their bladder. Diurnal refers to daytime wetting, but we're more interested in talking now about nighttime wetting or nocturnal enuresis. There are a lot of different causes related to this, and it's a frequent or common problem. Even 15 to 20% of 5-year-old kiddos will still have some nighttime wetting. There's a yearly spontaneous resolution rate of up to 15% per year, which leaves us then with about 1 to 2% of even 15-year-olds, so mid-teenagers, that still have some nighttime wetting. So very common, but often resolves on its own. Some of the most common reasons for some of the nighttime wetting: bladder spasms, stress or psychosocial changes, so a move, a divorce, some bullying at school, any of those kind of things that put stress on the kiddo. There's a genetic predisposition to it. In fact, we frequently see this run in families. We'll find out. We're talking about it in a well visit, and comes out of the woodwork that an uncle wet the bed until he was 15. So you might see it in families. Sleep problems are another relatively common reason to have some problems with nighttime wetting. So if your kiddo is snoring or has apnea, where you observe them actually holding their breath, that sometimes can increase risk for nighttime wetting and deserves some attention or evaluation in the doctor's office. Some kids are just heavy sleepers and don't wake up with the signal from their bladder to their brain, but don't necessarily have apnea that can be managed. And then there are other medical conditions like spinal disruptions. So that might be a genetic or malformation like spina bifida, but also can be related to trauma. Diabetes will cause increased blood sugar. They're wasting the glucose in their urine, so they make more urine. But more relevant to our topic, constipation is a common culprit to increase nighttime wetting. And then urinary tract infections are another potential trigger or cause. So constipation, super common topic. Here is a quick chart about the typical types of stool sort of classified. The first 3, type 1, 2, and 3, are considered constipation from severe to mild. Types 4 and 5 are more considered normal stools, and then 6 and 7 are to the opposite end of the spectrum, more loose or diarrheal type stools. It's important to also notice that, or also know what are normal stool patterns for the different age groups. So beyond just the texture of the stool, but what's the frequency of their stools. Early infants average about 4 bowel movements per day. Later infancy and toddlerhood, they usually average about 2 stools per day. One caveat to that is our breastfed infants later in infancy can have a stool even as infrequently as once every 1 to 2 weeks without being constipated. And then childhood and adulthood, the average is 1 bowel movement every 1 to 2 days. So that's more normal patterns independent of the stool type. Constipation in our office, we almost always find that it is functional, and it just means without an organic cause. But there are some organic causes that can lead to constipation. The functional pattern usually starts with a kiddo having a hard stool, and they think, ouch, that hurt. I'm not going to do that again. And then they start to retain the stool or refuse to pass a bowel movement. When they do that, then that stool stays in their rectum longer, and the body reabsorbs more fluid, which of course compounds the problem by making the stools harder and larger, which then when it does pass causes more pain and completes the cycle or continues that cycle then. Over time, their rectum gets stretched out, and they have decreased sensation, so the signal from their rectum to their brain doesn't get through as well. And we can end up even to the point where they can be incontinent of stool or lose past stool without knowing it. And up to 4% of school-age kids can suffer from this stool incontinence because of chronic constipation. Some of the more structural causes for constipation are going to be more identified very early in infancy, and they're more deformities, anal stenosis, where the actual opening doesn't even happen, cystic fibrosis, spinal deformities again, Hirschsprungs, things like that. They're identified much earlier in infancy. And then metabolic problems like hypothyroidism or even diabetes. The functional triggers have a lot of triggers. We talked a little bit about pain, but sometimes it can just be during times of transition. So for an infant transitioning from breast milk to formula or whole milk, they can experience temporary constipation. Toddlers with initiation of toilet training is a very common time to experience some constipation that can then progress. And then in childhood, often we'll see kiddos who first start school not wanting to pass stools in a toilet that isn't at home, and that can lead to some constipation problems as well. So what do we do about all of this? So that nighttime wetting has a variety of different approaches, and there's a fair amount of overlap in treatment for nighttime wetting as well as for constipation. So most commonly we use behavioral interventions. So having a nighttime routine that usually includes decreasing fluids after dinner time, so not drinking as much water or liquids after dinner, having a bathroom break at the start of the nighttime routine and at the end of the nighttime routine just before they get in bed, having parents take the kiddo to the bathroom when parents go to bed, and then even in the middle of the night if parent wakes up for whatever reason, that's a good opportunity to take the kiddo to the bathroom again. There are bedwetting alarms, so these are moisture sensors that can either be in the pajamas or underwear or a mat that's under the sheet that is then connected to a sensor that sets off an alarm when the mat senses moisture. The goal is to wake the child up before they completely empty their bladder so that they recognize when they need to go, they get up and go to the bathroom. These can be quite effective, but they do take some time. It can take up to 16 weeks to get dry nights every night. They are not covered by insurance. They'll run you somewhere between $20 to $300 if you check Amazon. They do have the best long-term results, though, even compared to medication management. Our medication options do include a couple of different things. There are medications directed at decreasing urine output, and then medications directed at decreasing bladder irritability, like ditropan. Both of them do not provide great long-term solutions and can have some potential side effects, so we tend to reserve those for more significant cases, or the medications that decrease urine output we'll sometimes use for camp or for sleepovers so that these kiddos can participate in some activities that they might otherwise feel embarrassed or miss out on. Some alternative therapies, things like hypnosis, acupuncture, chiropractic work, don't really have any evidence that they are effective and so usually are not used. It's important to remember as parents when this is frustrating and you're doing the 7th load of laundry in as many days that it's involuntary. These kiddos aren't being naughty. It's not a willful thing. It's something that they can't control. So as a parent, it's important to be patient with them and encouraging, age appropriately. As they get into grade school age, they can even be starting to help with doing the laundry, and taking some ownership of this can help them feel a little bit empowered as well. But again, it can be distressing for everyone involved, the kiddo included. So it's important to remember that everybody should take a deep breath and be patient with themselves over this. For constipation, we have a lot of different interventions and ways that we try to approach this. Often there is a lot of focus on dietary changes. The concern about food allergies, intolerances, in particular dairy, doesn't really actually have a whole lot of evidence behind it, and somewhat controversial in the literature. But I'll tell you, in my practice, I sure see a lot of kiddos that if you cut back on that whole milk and cheese, they do a little bit better. There's a lot of evidence that fruits, fiber, and water are very helpful increasing fruits, fiber, and water, is very helpful in bowel habits. In particular, for the fruits, prunes and pears, I tease that it's like Sesame Street for pediatricians. Fruits that start with P make you poop. They actually have more sorbitol, which is an osmotic agent, meaning it draws more water into the stool, makes it softer and easier to pass. Increasing fiber in their dietary intake can decrease the need for long-term use of other over-the-counter medications to manage constipation. And then we all could probably do a better job of drinking more water every day, these little guys included. I have a lot of kiddos that do a lot better drinking water every day if they get their own water bottle that they get to fill up and keep in the refrigerator or decorate somehow that's more fun. A lot of behavioral interventions, and we'd spend a lot of time in the office talking about these behavioral interventions for constipation, is often like retraining, especially as we get into the preschool and grade school age when we're having continued problems with constipation. It's like we have to retrain that message. Those signals from the rectum to the brain have been ignored long enough, and that intestine again gets stretched out enough that we have to really work hard to get them back into a healthier bowel pattern. So these can include scheduled bathroom visits after meals. So having kiddos sit on the toilet for 5 to 10 minutes after each meal to take advantage of the reflex of you fill your stomach and it starts your intestines moving. Making this a fun time for them, a special book, or maybe that's when they get a little bit of their screen time for the day, so that it's not a punishment to go sit on the toilet, but just some time, 5 to 10 minutes. And if they have a bowel movement, then we move on to that next stage of rewards. So maybe it's a sticker chart, maybe it's a little piece of candy, something simple and small, but a big party if they do have a bowel movement on the toilet then during that time. And even if it's, of course, outside of that time after meals, if they have a bowel movement, having a reward or a sticker chart to encourage them to continue in their progress. There are some behavioral therapy, like actually going to a psychologist or a therapist. There are some times where that has value, but it's generally in the context of when we have other behavioral or sensory concerns and not just the average kiddo dealing with constipation. Medications that we have available primarily are focused on osmotic agents. So this is Miralax in particular, but also magnesium citrate can be used. Miralax is probably the most common. It's a very safe medication that's been around for a very long time. It can be used as a clean-out to entirely vacate the colon, but can also be used as maintenance therapy to help keep the bowel movements, the stools soft, and while we're retraining. So this is often a longer-term therapy, even months, that we use every day to keep those stools soft while we're retraining that bowel and brain to work together and get their habits back on track. Sometimes we need to evacuate first, and then we'll use a suppository or an enema to kind of jumpstart things, and then again back to the Miralax every day to keep things going. We're learning more and more about probiotics. They are important bacteria that help us digest our food properly. They can be taken as a supplement and have a lot of value in a lot of different digestive problems, including constipation. There are some great options available over the counter. It doesn't really matter necessarily brand or anything like that, but a probiotic supplement can have some value. There are also stimulant laxatives like Senna or Dulcolax. We tend to reserve these for kiddos who are more resistant to other treatment modalities because they have some more potential for side effects like gassiness, bloating, discomfort with them. There are, if we continue to have difficulty managing symptoms or limited success or lots of backsliding, we will then refer on and use our gastroenterologists. The interventions that they have available are the same medications that we talked about, but also sometimes Botox if we've got problems with that sphincter, the opening is too tight, and sometimes even surgery for kiddos. But again, these are more along the lines of anatomic problems or abnormalities related to their constipation. So our biggest challenge with constipation is often the relapses that these kiddos have. So we can clean out their colon and they have a couple of days where their stools are nice and soft. But if we haven't retrained, then we're right back where we started. They fill back up again and we have hard stools. It can feel very frustrating and discouraging for parents to have to continue to do a medication every day or to have the kids sit on the toilet after every meal or to be washing sheets every night. It gets frustrating for everyone involved, but it is a long-term process with lots of potentials for relapses, again, with any potential transition times or changes in their life or stressors to these kiddos. So just remember, you're not alone. A lot of parents go through this. We see this all the time in the clinic and spend a lot of time talking about constipation, bowel habits, nighttime wetting, all of these concerns. So that was a pretty quick run through of all of that. Hopefully something in that was helpful for all of you guys out there. Please, if you have any other questions, let us know.
Thanks, Dr. Hansen. And thanks, everybody. We'll close out the webinar.